I really was pleased to be asked to talk today because it gave me a chance to think about some of the experience that I've had over the years in both working on measurement and then collaborating with learning health systems and trying to incorporate consistent measurement in the work that they're doing. What I want to try to do in my time this afternoon is to build and extend on some of what Dr. Friedman was talking about in his address and give some examples from my experience that relate to the principles that he was talking about. And then I'll share some insights that I have gleaned over the years in working with learning health systems, specifically in efforts to adopt a common outcome metric in their work. Dr. Friedman talked about the traditional model of the transition from science and the development of evidence and new knowledge and trying to get it into healthcare. And he talked about the fact that there are many missed opportunities, there's a lot of waste, and there's a lot of delay in getting new information and new evidence into practice. And he made reference to the research gap of up to 17 years in getting new evidence into clinical practice. And he made the argument that we need a more efficient, effective, and safe system for more rapid progression of knowledge into care and into practice. And it makes a lot of sense. And I want to share with you this afternoon some of my experience from the perspective of someone who does work on developing measurements. Now, from the measurement challenge, as I look at it from my perspective, is that we've had slowed progress quite dramatically in the field of rehabilitation and healthcare at large because of what I would refer to as let a thousand flowers bloom approach to outcome measurement, in which every organization and every group reinvents the wheel and comes up with different variations of sometimes very similar measures. Standardizing health outcome metrics across healthcare settings, in my view, would be key to expanding the creation and the dissemination of new knowledge in healthcare in general and rehabilitation specifically. When I started my work in outcome measurement and collaboration with learning and other health systems, I viewed it in a fairly simplistic way. And I think I would best characterize my initial thinking of similar to Curly in the movie City Slickers. And I know I'm showing my age here, but those of you who aren't familiar with this movie should take a look at it. In that movie, there's this old curmudgeon whose name is Curly, and he's a cowboy, and he's talking to these city slicker guys who are out on the range with him, and he asks the question, do you know what the secret of life is? And he holds up a finger, and Curly says, it's this. And Mitch, one of the key city slickers, says, oh, your finger. And Curly says, no, one thing, just one thing. You stick to that and the rest don't mean shit. And so Mitch says, well, what's the one thing? And Curly smiles and says, well, that's what you have to find out. And I kind of viewed outcome measurement that way in some of my early work. We kind of approached it that way. Our feeling was if you developed really good outcome metrics, people would grab hold of them and they would adopt them and use them in practice. And that was kind of my city slickers approach to outcome measurement. Well, I've learned in the years since that it's far more complicated than that. One of my colleagues, Gene Nelson, wrote a piece back in the late 1990s on principles of measurement, both design and application. And I think he put his finger on some, what I see as key elements that really will help get measurement adopted into clinical practice. The first principle Nelson talks about is keeping measurements simple. Start small, keep it simple. And then focus on usefulness, not perfection, in our measurement. These are really obvious but very challenging principles to follow. He also emphasized the importance of establishing clear operational instructions on how the measures should and would be used so that you get consistent information from the measurements. And then from the application perspective, Nelson argues you need to develop a measurement team within your organization and then build measurement into daily work. And I have to say, if you want a really great model of an organization that's really done this for years now, it's the group at Intermountain, Gerard Brennan, Stephen Hunter, and their group has, I think, really exemplified these principles in the work that they've done as a learning healthcare system. Well, as a measurement developer, back in the early 2000s, I developed a post-acute care outcome measurement called the AMPAC, my group and I at Boston University School of Public Health. And we were very excited about this measure. It was a generic functional measure. We felt it could be used across different patient conditions. We designed it so that it would be relevant, for example, with patients who had major musculoskeletal, major neurologic, and major medical conditions. We felt you could achieve better standardization if the outcome measure was generic. We wanted to design a measure that could be used across care settings. At that time, there was no functional measure that existed that could be used across different care settings. And so that was a key element in designing the AMPAC. And we did that because we felt it was really increasingly important to be able to look at function as a critical rehab outcome across the entire episode of care. We designed it so that it could yield consistent information from either the report of the patient or from a clinician or family member proxy report. And most importantly, we designed it so that it would be sensitive to clinically meaningful change, so that we could really use it to reflect change that was occurring in our patients across the entire episode of care. And it was meant to be a substantial departure from the existing metrics, which were all setting specific. The OASIS, the FIM, the MDS, all designed for specific care settings, and none of them talk to each other across the entire episode of care. So in order to do that, we used a contemporary approach to developing measures called item response theory. And that would allow us to achieve all of these goals and end up with a measurement approach that would be both practical and flexible for widespread use and adoption. So we were very excited about that. We also developed a really sophisticated approach to administer this instrument called computerized adaptive testing. And that's what really allows one to efficiently administer a condition-wide and setting-wide functional assessment without sacrificing precision or accuracy. And we published our first work in 2004. And in my naivete, I expected people would adopt it quite readily. And our experience was quite the opposite. Adoption was quite slow. And so since that time, I've learned a lot of lessons, some of which I'd like to share with you this afternoon. The first lesson is our assumption that if we built it, they would come, like the field of dreams, was really not practical, and it certainly wasn't going to help. We fell into the classic trap of doing the research, publishing the research, and figuring that our job was done if we did that. And as I have already pointed out, adoption was quite slow. So we were going to have to do more than just build it and wait for people to come. And fortunately, this is where we began to be introduced to and began to collaborate with rehabilitation learning health systems. And I want to share some of my experience with you that I've had over the years in collaborating with learning health systems around measurement metrics. And to begin with, I'll go back to Dr. Friedman's learning health system, the learning cycle. And he talked about the P2D phase, performance to data, the D2K phase, data to knowledge, and the K2P, knowledge to performance phase. And where we came into the picture was in the P2D phase, where by collaborating with the learning health system, we were able to help them develop a metric that would enable them to better establish their performance using metrics, using standardized measurement tools. So at the beginning of the learning healthcare cycle is where we tried to come into the picture. Now, my first exposure to doing this was with the folks at the Cleveland Clinic Hospital System in Cleveland, Ohio. This was my first really intense experience with collaborating with the learning health system. The folks at Cleveland Clinic came to us and they said they had read our work. They were aware of the research that we had done in developing the AM-PAC instrument, and they thought it had promise, but they felt that it was far too complex for what they needed in their institution. And they wanted to grossly simplify what I thought was grossly simplifying this instrument and adapting it for use at the Cleveland Clinic. Well, I was fine with it. So we got together with them, and they asked us to create a really scaled down version of the AM-PAC, specifically for them to use with acute care patients. And they wanted to, in each of the domains of the AM-PAC, they wanted us to select no more than 6 items per domain so that it was really practical and easy to use within their acute care institutions. And so we developed a short form with AM-PAC items, 6 items to assess mobility and 6 items to assess daily activity. I have to admit, my prediction at the time was that this was going to be far too crude to really yield useful information. But I went along with it. They were really good people, and we developed the instrument looking carefully at our data and then gave them the short forms. Well, they went back to Cleveland and they rebranded the AM-PAC, the acute care short forms, as 6 clicks. And the 2 key players in Cleveland Clinic were Mary Stilfen, who is the head of rehab services, and Fred Frost, who is then the head of rehab medicine at Cleveland Clinic. And so really the lesson that I learned there in working with Fred and Mary at Cleveland Clinic is listen to your users. Your users know what they need in their setting. And so we really began to listen to them, and we began to try to develop measurement metrics that met the needs of our clinical partners in the learning health system. And the success that Mary and Fred had at Cleveland Clinic in the early days was quite remarkable. Mary and her team began to use the data from the 6 clicks to change referral patterns to physical and occupational therapy within Cleveland Clinic acute care. And because of those changing referral patterns, she began to be able to reallocate her rehab staff to high need areas without having to add new staff. And then they began to use the data from this common metric for discharge planning. And they began to institutionalize the use of standardized functional metrics using the 2 6 clicks short forms and how they practiced at Cleveland Clinic, and they were extremely successful. And those of you who have had the opportunity to listen to Mary talk about her experience know she's an extremely effective change agent. And so that was my initial experience with collaborating closely with a learning health system. And then shortly after that, I was contacted by the folks at Johns Hopkins Hospital, Mike Friedman and Dale Needham. Mike at that time was heading up rehab services at Johns Hopkins, and Dale Needham is a physician who heads up the ICU services at Johns Hopkins. And I knew Dale from other experiences, and got a chance to meet and get to know Mike. And they were very interested in the work that Mary and Fred were doing at Cleveland Clinic with the AM PAC. And so they began to use it in their hospital system. And again, a learning health system. And they really began to expand the efforts system-wide at Johns Hopkins. And they've created an entire system-wide activity and mobility promotion initiative, which they call the AMP initiative. And it's become system-wide at Johns Hopkins. They offer training and conferences for people all around the place, really focusing on using metrics as a starting point to mobilize patients in acute care and across the Johns Hopkins system. And one of the notable accomplishments that Mike Friedman and his colleagues achieved was getting the nursing staff at Johns Hopkins to routinely begin to collect mobility data on their patients. I'll never forget the first meeting I went to with Mike, with all the nursing directors at Johns Hopkins early on in our collaboration. And I must say, it was eye-opening to me. I didn't think he had a snowball's chance in hell of ever getting them to begin to collect mobility data on patients, but he is very creative, very persistent, and he was successful in getting the nursing staff to begin to routinely collect this information. The other thing that we began to do in collaborating with the second learning health system is we began to expand the short forms that we could develop off of the AM PAC instrument, which was one of the original goals that we had not been successful in achieving. So the folks at Hopkins wanted us to develop a short form of AM PAC items specifically for home care patients. So we did that. And then they wanted us to develop a short form that they could use to assess community mobility. And what was really nice and unique about doing these short forms is that by converting the raw scores to standard scores, they would be on the same metric as the acute care 6-click short forms. And so they were beginning to knit together a common metric that could be used across care settings, even though they were creating separate short forms, but underlying the short forms was the common AM PAC metric. And so they began to expand the use of a common metric across different care settings where the Hopkins folks were involved in providing care. So those were, from my point of view, two incredibly fertile environments for me, a measurement developer, to really begin to have some success in getting people in the learning health system to actually begin to use and adopt the metrics that we had developed. Now, the other lesson that I learned in doing this work is that the more people you can bring into the collaboration, the better, and the more you're able to learn and expand on it. So early on in my work with the folks at Cleveland Clinic, I connected them with a colleague of mine, Dr. Diane Jette, who at that time was also at the MGH Institute in Boston. And she was just about to start one of her sabbaticals, and she and I had done research over the years during her other sabbaticals. And I thought she might be interested in what the folks at Cleveland Clinic were doing. And so I connected her with Fred and Mary. She went out to Cleveland one February, and she began to develop some research projects with them using the 6 clicks. And so that led to several really useful articles that are now in the rehabilitation literature, illustrated here, establishing a better scientific basis for what they were doing at Cleveland Clinic. So that was an exciting expansion of the work. And it was great for Diane because she had something to really focus on for her sabbatical. It was very productive, and she had the opportunity to visit Cleveland in February, and who wouldn't want to do that? And then we further expanded our collaboration through working with the COSTAR, the Center for Health Services Research in Physical Therapy, that was funded and is funded by the Foundation for Physical Therapy Research. One of the initiatives as part of the COSTAR initiative was what we referred to as faculty fellows. And these were junior faculty members who were looking for opportunities to collaborate with learning health systems to both help them and to help them themselves develop their scholarship and research. And I had the good fortune of working with 2 faculty fellows, Dr. Danny Young and Dr. Carmen Capalugo, both of whom collaborated with Mike Friedman and his colleagues at Johns Hopkins, and really began to assist them in expanding the research around the work that they were doing at Johns Hopkins. And that led to another series of papers, and it also led to a collaboration between Johns Hopkins and the University of Pittsburgh Medical Center, both of whom had come to me saying that they were interested in using the AIMPACT metric for very low functioning acute care patients, particularly those in the ICU, but they were finding that the current measure had serious floor effects when used in ICU and other very low functioning patients. So I collaborated with them, and both Carmen and Danny worked closely with Hopkins and UPMC to expand the floor of the 6 clicks short forms that were being used in acute care so that they would be more relevant and appropriate for very low functioning patients. And that work has subsequently been published. And they also did further work on looking at reliability of using these standard metrics when used by nursing versus therapy staff, and looking at prediction of hospital disposition by various levels of function. So really began to expand the science behind the work that was being done at Hopkins, much like Diane Jette had done in collaborating with the folks at Cleveland Clinic. And so working with my colleague, Mary Slavin at Boston University School of Public Health, we decided with that early success, it would be nice if we could expand the network of learning health systems and health service researchers to try to bring them together to really expand the kind of research that was going on at Cleveland Clinic and Hopkins and UPMC and University of Utah and so forth. And so we began to do annual clinical users workshops. This flyer comes from one that we did in the spring of 2017, where we brought about 100 people from around the country who were either involved in or interested in doing collaborative research in learning health systems. We brought them together to begin to share their experience. We had posters, we had keynote speakers, we had plenary and breakout sessions, and we really began to expand the network beyond the early groups that were working together. And I think we did 3 of these, and really it helped us expand the network of collaboration between health services researchers in rehabilitation and learning health systems. And that kind of opportunity, as I look at it, is being expanded even further through the LeaRRn network. And the LeaRRn Health System grant has a scholar program. And what they are going to be doing is pairing rehab researchers with health system stakeholders to establish meaningful partnerships to begin to expand the research that's going on within the learning health system. And they're also providing mentored pilot study funding to really help get this work off the ground. I think that's an exciting expansion of the work that had begun under CoStar, and now it's being done much broader than in physical therapy through the LeaRRn network. So in conclusion, I'd have to say, to some extent, Curley was right. There is one key thing behind all of this collaboration, and that is teamwork. If I've learned anything over the years in collaborating with my colleagues in the various learning health systems, is that if you work with a team of really creative people from all over who have common interest, you're going to have a lot more success than if you really focus and do your own work in isolation. And I've tried to show you some examples of that through my experience today. So thank you, and I look forward to the small group discussions.